The Breath of Life, tonight on Call. Funding for On Call television is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call television as it continues to open doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Dakota Care, the Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, Dakota Dermatology, Aberdeen Asthma and Allergy, the Orthopedic Institute, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation. We live in an ocean of air. We hunger for it when we exercise and relax when we exhale and sigh. But what can we do when that easy flow is interrupted? The breath of life when the doctors are on call tonight.
I was looking for a breath of life, for a little touch of heavenly light, but all the choirs in my head said no.
Hello and welcome to On Call Television. Tonight's show is on the subject of respiratory conditions, lung trouble, pulmonary disease, or to say it most clearly, it's all about breathing. We're talking the obstructive lung conditions of asthma, chronic bronchitis, and emphysema, restrictive lung diseases like pulmonary fibrosis, infectious pneumonia, and heart failure. There's farmer's lung and coal miner's lung, pigeon breeder's lung, hypersensitivity pneumonitis, valley fever, farmer's lung, tuberculosis. There's sleep apnea, sinus obstruction, lung cancer, cystic fibrosis, and the list goes on with conditions that could affect your lungs. Have you had shortness of breath, a cough, a sneeze that's been bothering you? Tonight is your opportunity to ask questions about the respiratory system. Call us at 1-888-376-6225 or email us at questions@oncalltelevision.com. With us tonight is friend and expert pulmonologist Dr. Mike Pietila of Yankton to help answer your questions about what might take your breath away. And what kind of a name is Pietila? Where did that come from?
Well, Pietila is a Finnish name.
So you've got a Finnish background.
Yeah, it's only a small part of my ethnic makeup. I'm mostly German, but enough to carry the name.
Yeah, your mom is a Cruz from De Smet.
Correct.
How well I know. I mean, I grew up with your mom.
Right. She's told me stories.
Has she?
She has.
Right.
Right.
That's really. So where did you train?
I went to undergrad right here at South Dakota State.
Oh, I see you have an SDSU.
My Jackrabbit tie on tonight.
Yeah, go Jackrabbits. Yeah.
Very proud and supporter of the Jackrabbits, and then I went to the University of South Dakota School of Medicine.
So you're a AC/DC or whatever they say. I don't know how that goes.
I'm a graduate of the University of South Dakota School of Medicine.
Yeah, me too.
Right.
All right, and then what did you do?
Then I went over to Rochester, Minnesota, the Mayo Clinic, and did my residency in internal medicine, and then fellowship training in pulmonary critical care and sleep medicine.
All three of those.
All three of those.
And so it's interesting. You point out, you make a point, and this is an important point. You're an internist first.
I am an internist
like
first.
I am.
Yep.
Of course, I dropped out. You went on.
I decided to subspecialize. It doesn't mean that you dropped out.
Okay, all right.
Yeah, we are both fellows of the American College of Physicians.
Yes, we are, and proud of that.
Correct.
So, pulmonary medicine in Yankton.
Mm-hmm.
So tell us, how long have you been there, and what's that all about?
You know, I arrived in Yankton in 2006. And joined the multi-specialty clinic in town, the Yankton Medical Clinic. It's physician-owned. There's a Vera Sacred Heart Hospital in town as well. But I joined a practice with Dr. Lori Hansen, who's the dean, dean of the Yankton Medical School campus and a pulmonologist as well. And then we have primary care providers and other subspecialists. And And we work with the School of Medicine and care for patients and educate students. And
tell me a little bit about the School of Medicine in Yankton. See, now has led the nation, really, hasn't it, in how to teach med students. And actually, Harvard came out here to look at the Yankton campus about how to do it. What is it about Yankton that...
Well, there's an ambulatory style of training called the Yankton Model Program, and that established in 1991, I believe, was the first year. And it's a different way to teach medical students that's more consistent with the way that we teach residents and so forth. It's, instead of blocks of training, it's a continuum of care across a longitudinal form of teaching, so that students learn along with patients on a year-long or 2-year basis instead of in 8 or 9 week blocks.
Right. So I had anatomy, and then I had physiology, and then I had microanatomy, and then I had pathology. And what they're doing now is all of those at the same time while you're examining patients and having patient examined.
Right. And taking it a step further, then when you went from those basic science courses, then you went to where you did your internal medicine for a block, and then you did OBGYN for a block, and then you did surgery for a block. And the way that we're teaching now is across that spectrum, so you're learning all of those things throughout the year so that you're not just getting exposed to one specialty at different times, you're getting exposed to all of those cares for the patient as you're developing what you want to do and becoming a better student and hopefully a future physician.
And it's interesting that they did this out of necessity, a small campus, that type of a thing, but the result is that the improvement in their learning, I mean, the passing of tests surpassed a lot of other places in the country, and the improvement was higher and faster than anywhere else.
Right. And so Dr. Lori Hansen and Dr. Talley, our retired dean, have done the research to put the numbers together that demonstrate not only do students do equally as well, but often better on average on standardized tests to determine the knowledge that's learned. And we think that's because it's across a continuum of learning, which is the best way to learn anything as opposed to block learning.
Right. So what is your place in this world of Yankton? You know, you do intensive care unit and the and then outpatient pulmonary disease. So explain your world a little bit.
Yeah, so my typical day is I get up and go to the hospital and see patients in the intensive care unit or on the medical wards. Most are pulmonary patients, but some are my general medicine patients as well.
Most of them, that's, people with heart failure or lung, chronic obstructive lung disease, emphysema, asthma.
Right, across that spectrum. So you can end up in the intensive care unit for a variety of reasons. You might have perfectly healthy lungs, but you've done something to injure yourself and you can't breathe on your own, so you're on life support. That's in the ICU. Could be a heart attack, could be sepsis from an infection like pneumonia. Could be that you have chronic lung disease and you can't any longer breathe on your own because of illness, so you're in the ICU on a ventilator. I usually have a medical student with me a day or two of the week, and then finish my rounds there and head to the clinic and see patients in a consultative and follow-up manner, primarily for lung conditions on the referral of a number of physicians and other care providers throughout the region.
So it's an important thing for us to take advantage of this wonderful expertise that we have available, and I need you to make your phone calls. 1-888-376-6225, anything about the lung. I mean, we can go anywhere you want about the lung. We could go anywhere you want about anything else too, but because he's an internist, he knows everything. But his expertise is lung. So let's get your calls in. 1-888-376-6225, or email us on calltelevision.com and click on the question button. So what is the most common thing that you see?
Well, probably the diseases of chronic obstructive pulmonary disease and asthma. Probably leaning a little more towards COPD.
Now, what is, it used to be asthma, emphysema, chronic bronchitis. Now people are talking COPD instead. Explain that, what's happened.
It's not easy to explain it, but COPD, or chronic obstructive pulmonary disease, is a disease that's chronic and common, and it's the insidious onset of shortness of breath, and the shortness of breath is not completely correctable. So asthma is a disease that can develop normally develops in childhood and can be treated, and the obstructive airflow can be reversed. In chronic obstructive pulmonary disease, it's usually smokers, but other patients exposed to chemicals or dust that injure their lung, and they develop a chronic and continuous symptomatic disease.
Right, and mostly this group chronic bronchitis, emphysema, asthma, have trouble getting the air out. You know, they can get the air in, but it takes them a long time to get the air out. Now, compare obstructive lung disease with restrictive. Restrictive lung disease like pneumoconiosis or pulmonary fibrosis.
Yeah, so separating obstructive from restrictive, they can have similar symptoms, cough and shortness of breath, but the difference is that in patients with restrictive lung disease, their lungs are actually too small. They can't get enough air in. They have scarring for a variety of reasons, and so they just don't get enough air, and then of course they don't exhale enough. In the obstructive pulmonary diseases, they oftentimes, in theory, can breathe in enough, but they can't get the air out. And so when they try to forcefully exhale with activity, they become very short of breath. Restrictive lung disease, too small a lungs.
Too small a lungs. So the classic story is that of pulmonary fibrosis, where it turns into scar. Are we seeing more of that pulmonary fibrosis?
I don't think we're seeing any more than usual. We're recognizing it perhaps earlier. You know, you have to watch for particular things. There's the idiopathic form, IPF, which
in other words, you have no idea what.
No idea why it occurs. It's not common, but it does occur, and patients can't do anything about that. It happens, and there's nothing they did wrong or anything they can do to control it. But there are other causes that can be related to exposures or, in many instances, medicines. That's probably where I see most of my new restrictive lung diseases, from toxicity from other medicines.
Okay, let's go through those lists of medicines, because patients probably aren't always informed about the potential risk of those medicines. What medicines are the biggest culprits in causing pulmonary fibrosis?
My colleagues in cardiology aren't going to want to hear me mention amiodarone.
Oh, we wouldn't want to mention amiodarone.
But it's a medicine that's commonly used to treat heart rhythm problems, atrial fibrillation, but it's used in a variety of other rhythm problems because it is a very effective and relatively safe medicine as far as those go. However, not in an insignificant number of patients, it can cause a reaction in the lungs that can lead to sometimes permanent lung damage, and it's not usually immediate.
So I put a patient on amiodarone 2 days ago for a run of VTAC. They were having an abnormal rhythm. We wanted to stabilize them. We dripped amiodarone, but it's going to be a short 2-3 days. Any danger there?
Usually not. So it's not usually an acute reaction. There can, in rare instances, like any medicine, be an allergic reaction to it, but normally it's more insidious over 8 months or 10 months or 12 months.
Okay. And so what other medicines can cause pulmonary fibrosis?
There's a medicine commonly used to prevent urinary tract infections, macrobid or nitrofurantoin. Older patients, or sometimes women especially, placed on it to prevent urinary infections. That can lead to injury to the lungs. And then any chemotherapy, many of them can be. Yeah,
the chemos are the big ones.
Yeah.
Have you seen many macrobid or macrodantin or nitrofurantoin pulmonary fibroses? Because, boy, some of us would say not used enough, because it's a great antibiotic, because we only use it for the bladder, and it works.
Yeah, and it won't cause problems when used in the short term. So no, I wouldn't say it's something you should shy away from to treat infections that you anticipate, a 7 or 14-day course. But when used chronically over months or years, especially in older patients, it is associated very clearly with development of a fibrotic condition in the lungs.
Right. Well, I've gone away from using it chronically.
Yeah.
But boy, we don't want to be afraid of using it short term, because it's a lot better than using it Cipro or Levaquin, which it can cause all these overgrowth problems. And it has a rare macrobid, or nitrofurantoin has a low incidence of C. difficile overgrowth infection. So I wanted to put those particular things in. 1-888-376-6225. This is your show. Call in and give us your questions. So what other problems cause pulmonary fibrosis? Let's talk about farmer's lung, for example.
Yeah, so there are a variety of different reactions that can occur due to exposures. And in the Midwest, we have lots of farmers, and there's farm dust and hog barns and other confined livestock. And some patients or people, when exposed to those, will have a reaction to the bacteria in the soil.
And so they gradually, over a period of time, have a problem with fibrotic kind of a lung disease, restrictive lung disease, not asthma, not obstructive, but a restrictive process.
Yeah, it's kind of a mixed pattern, but it's separate from an acute reaction. There can be those. You get exposed to something in the silo or something in the barn and you're sick immediately or shortly thereafter. But the true definition of farmer's lung is a more chronic condition, and they're not really aware they're getting into trouble with it until after many years, and then it's often too late to reverse the process. So it's important for someone who's being exposed and might be having a reaction to consider discussing that with their physician.
All right. Chronic obstructive pulmonary disease, or COPD, is a lung disease that makes it hard to breathe. The main cause of COPD is smoking. After decades of this nasty habit and working in a dusty farm and stockyard environment, one patient is on oxygen therapy 24 hours a day.
I think I started smoking probably right out of high school. I always worked around people that smoked. We were living on a farm, we always had hired help, and most of those guys smoked. And so I suppose I bummed cigarettes from them, and that got me started. We ran out of cigarettes and in a blizzard, and I rode my saddle horse 6 miles to Bushnell back to get some Bull Durham to smoke, because we just had to have cigarettes. Well, after I got married, we farmed, and I smoked all the time. We smoked everywhere. I mean, I smoked in the car, I smoked in the house. I couldn't wait to get done eating so I could have a cigarette, breakfast, dinner, supper. Every cup of coffee, had to have another cigarette. Worst thing was, of course, that I smoked in the car with the kids and my wife, which when I look back, it makes me mad to think I did it, but I did it. When I was smoking, I burnt holes in my shirts. I burnt holes in car seats. It's a dirty habit. It's an expensive habit, and I just wish I'd have quit a lot quicker. I wouldn't have this on. I'm on 24-hour oxygen. I have a tank that I carry in the car. Yeah, I sleep with it on all around the house. It's full time. I am so thankful that I quit, and wish that I had quit a lot quicker. I wouldn't have this problem. And it bothers me a lot when I see somebody else smoke. After, I kind of probably shouldn't, because I smoked so many years myself. But I just can't help but think, why can't they quit, or why don't they quit?
I want to thank that gentleman, Mr. Peterson, for having the guts to say it and to put himself out there and to show his vulnerability and his honesty. So thank you very much, Bob, for doing that. And that is enough to say he is making this point that we really shouldn't. People realize they shouldn't be doing this. What is do you have a recommendation about smoking? I mean, how do you get people to quit smoking, or you? Or
well, yeah, you and I can't get someone to quit smoking,
No.
right? They have to decide that they're going to stop smoking, and so you have to first recognize that it doesn't do any good to tell patients you need to stop. That's not enough. So when a patient comes to see you as a smoker, for whatever reason, whatever they might be in for, it could be a stub toe. If you know they're smoking, it's important to ask them about that and suggest to them that they ought to stop and that you're there to help them. And most smokers want to quit.
I think they do. And probably the one most effective method, which isn't great, but is one of the most effective methods if the doctor keeps bugging them.
Yeah.
I think and I have a number of patients who have quit. I would take a little bit of credit, but it's their guts to take it. It's hard to quit. They say it's harder to quit than cocaine abuse.
Yeah, and I don't know that I can comment on cocaine abuse. I don't treat many cocaine addicts.
I don't either.
I treat a lot of smokers, and the key thing is to keep encouraging them to consider stopping. And when they're ready, then provide them assistance. And there are great medicines out there and other things that can help them quit. And the biggest thing I tell my smokers is, when you're ready, don't be afraid to try and stop. Some are just afraid of the failure of trying to quit, and I consider that part of the process.
Yeah.
when you try to.
What do you think about e-cigarettes? There's a lot on the you hear it everywhere about e-cigarettes. It's an addiction too.
Yeah, it's an addiction too. They're not a safe alternative. They don't help people quit smoking. We're already finding that out. When people say, I'm going to quit the real cigarettes and just smoke the e-cigarette, it doesn't work that way. They smoke both. And so number one, they're not effective at stopping smoking conventionally, and number two, they're harmful, not in the same ways we don't think as regular cigarettes, but they're harmful on their own. And so it's just a perpetuation of the addiction, and likely, if not as harmful, potentially more harmful because they don't work to stop.
How about tobacco in the smokeless tobacco?
Yeah, so chewing tobacco in any form is not a safe alternative. That's the term that we would use. And so chewing tobacco is associated with its own potential significant health risks.
The cancers of the throat. I've had enough people who've lost their face and their tongue and their throat from the smokeless tobacco. So there are good options. What are the things that you use?
Well, again, it's a matter of making sure the patient's ready to quit. You can't put anyone on a medicine to help them stop unless they're ready. Once they're committed and ready, we develop a quit plan between the patient and I. That's tailored from person to person. It's not the same for everyone. And then there are options like nicotine replacement, which are the patches, the gums, the lozenges, the nicotine inhalers. There are medications like Zyban or bupropion, which is an antidepressant, anti-anxiety
Wellbutrin,
agent.
same thing. All of those.
Same thing.
Zyban,
All the same.
bupropion, Wellbutrin.
Yeah. And then there is one called Chantix or Varansolin, which is a direct inhibitor of the effect of nicotine in the brain itself. And Chantix is the most effective, about 45% effective in patients who are committed to quitting and having them smoke free.
And I've had some people on Chantix and the bupropion as well. I'll do anything to help them get off of it.
Yeah, and there's a lot of bad press out there about Chantix that will cause.
What do you think about that?
Well, it does have some subtle side effects, especially early in treatment, but they get better the longer you're on the medicine. In only the rarest of instances is it a severe reaction. It shouldn't be used in patients who have severe depression or a history recently of depression symptoms. But the fact you have depression doesn't mean you can't take it.
I think some people who smoke really do have depression, and that's part of their self-therapy. I've heard that hypnotism works.
Mm-hmm. So hypnotism is again an option for some patients who are committed to quit. Yeah. It's just another way of associating smoking with something dissatisfying, but. I don't know the numbers as far as the effect of hypnotism.
I think that if a person has convinced themselves that it's time, and they convince themselves that the hypnotism is going to help, it'll help.
Yeah, and I think that's the key thing. All of these treatments are most effective when the patient themselves is ready to quit smoking. And the job of the physician and the family isn't to nag at them or to say, you need to quit smoking or I won't treat you anymore, but it's to say, here's the benefits of stopping. Here are the hurdles that we'll encounter when you try to stop. Here's a solution to each of those things.
When I was an eager young physician, I used to jump all over them, and somewhere along the line I realized that they didn't want to come and see me. So what I would before I would start into my vigorous anti-smoking thing, I would say, now, do you want me to jump all over you, or how do you want me to handle this smoking thing? Because as a good doctor, I'm going to want to encourage you in that direction. I'll jump all over me and do your best. And then I have permission, you see. Let's jump into our questions.
Absolutely.
What is a rescue inhaler?
So a rescue inhaler is a short-acting bronchodilator.
Yeah, beta agonist, an adrenaline-like drug.
It's an adrenaline-like drug, you're exactly right. And back in the old days, we used to use adrenaline in those short-acting inhalers. Yeah. Patients used to, when they went away from those adrenaline inhalers, many of my patients said, well, how am I going to get by? I use this all the time, every day. The short-acting inhalers now are the albuterols.
4 hours.
Yeah, Zolpanexes. And they're not for regular treatment. They're to be used occasionally.
For a rescue.
You need them to get through an exacerbation, through acute symptoms. So anyone who's using albuterol, which comes in the forms of ProAir, Proventil, Ventolin, there's one I'm forgetting, MaxAir. If they're using that frequently, more than twice a week, then they need something for maintenance.
Right, which is what?
Well, those are the inhaled steroids in most instances.
And that's the big word, right?
Yeah.
Is steroids are really the way to help a person who has asthmatic type
Correct.
of
So asthma, we're separating this from from COPD now. Not that some asthma can't be COPD, but speaking of asthma, if you're using a rescue inhaler more than just for rescue, then you need to be on a maintenance therapy. And the cornerstone of that, the building block of that maintenance therapy, is the inhaled steroid family.
Now, there's a long-acting beta agonist and the short-acting beta agonist. They've both been found to be alone bad actors, right? What's that?
Yeah, so in particular, the long-acting beta agonist. So not so much the short-acting, but the long-acting beta agonists should not be used alone to treat patients with asthma. Okay, again, separate from COPD. So the Ceravents and Foradils of the world should not be used as monotherapy in asthma patients, because there was a study that showed an increased incidence
death
of
rate,
adverse reactions, and heart attack,
yeah.
heart-related deaths. So those shouldn't be used alone in asthma.
Yeah, so you always, but when you combine it with steroids, it's okay. In
Correct.
fact, I think it's okay because actually it's a trick. They like it, and they use it, and then they use the steroid because they don't commonly stay on the steroid.
And I see a lot of that. I see patients who are started on the combination agent, has first-line therapy. Advair, Dulera, Symbicort. Has first-line therapy for persistent asthma. And when you look at the guidelines and the stepwise treatment of asthma, it should be followed by the inhaled steroid first, add the long-acting beta agonist if necessary. I understand your trick theory, but many times I have to sort of back that off because patients don't need that extra medicine.
Right, and go to the steroid
alone. That's the cornerstone.
Except that none of them are cheap.
That's right. That's hard.
Radon. Can radon cause shortness of breath?
Won't cause shortness of breath. So radon is a chemical.
What does it do?
Found in the basements of homes. It's heavier than air. It's an inert molecule, so it's heavier than most of the chemicals in the air. Settles into the basements of homes. It's particularly common in the basements and areas of southeast South Dakota, northeast Nebraska, where I practice now. Radon has been associated with lung cancer. So it's felt to be the second leading cause of lung cancer after smoking. Smoking by far. If you're smoking, that's why you're going to get lung cancer. If you're not, and you live in a basement or spend a lot of time there, you should have it tested for radon.
Okay. So test for radon, although some people think that's been overblown and it's a...
and I think that it's not. I think it's something to know, especially if you're spending lots of time in a basement.
Okay, so test it. And how do you test it?
You just have someone come in and do radon testing. It's relatively inexpensive. If they discover that your radon levels are high, then you have to decide, do you want to mitigate that?
Can you go to the hardware store and find a radon tester thing?
There isn't one that I'm aware of that's approved. By inspectors or otherwise. I could be wrong.
All right, here's a question about Advair for years. Now, Advair is that combination thing. 15 years, is it danger in using it for too many years? Has coughing, asthma.
Yeah, so persistent asthma, again, is treated by a combination of medications. When it's persistent enough that you need something like Advair, the inhaled steroid and the long-acting beta agonist medicine together, Advair or Dulera or Symbicort, then it's important to be on that medicine. Now, it's part of the management is every 3 months or so I try to see if patients are stable enough to allow me to discontinue it, because there can be some increased risk for complications. Pneumonia, for instance, from the use
of... With the steroids?
Yeah, with the steroids, especially at the highest doses. But if it's necessary, the benefits, we believe, based on experience and science, outweigh the risks.
All right. Great. It's easy to confine our health concerns to the United States, but the same problems reach around the world, and their effects in other countries will have ramifications for us all as well. One of the articles that I've read through this center was about smoking in developing countries, smoking in China in particular. What's the information that's important there?
They are headed for a cliff. They only recently had a lot of people who could afford tobacco, and marketers have been rushing into the country, and it's very, very high smoking rate, not a whole lot of interest by anybody in cutting that smoking rate. It's mostly men. It's like in this country, we had men first, after World War II, I guess. World War II, people started smoking, and then 30 to 40 years later, we started seeing the cancers. And then it started later in women as they started marketing to women. In China, it is even more than we had. It is just going to be an incredible, incredible thing. They're taking care of some of their other diseases. Like they're taking hepatitis B, which can cause liver cancer. They are now working towards universal vaccination. They will no longer have liver cancer, which used to be the #2 or #3 cancer in that country. It will be gone. it is going to be well overrun by lung cancer.
Anything that we could do or should do, or as a network of worldwide countries to help them?
Well, reporters are usually loath to recommend action. What we like to do is expose problems. But in this case, getting the marketers to stop marketing tobacco there would be a great step.
Right. And how could that be done?
That's a great question. I am not schooled in political action. If you own stock in any of these companies and go to the stockholders meetings, the various medical groups have been very good about being ahead of, being right there with anti-tobacco messages. So I'm not going to say that that's needed because I think it's already happening. Maybe some of the medical groups could focus on China specifically. I don't know, they may be there already.
Call in your questions about respiratory illness or any issues of respiratory disease at 1-888-376-6225 or email us at questions@oncalltelevision.com. That was Joanne Silberner, the NPR medical reporter, and it was just a joy to meet her. And it was amazing what she had known or learned about illnesses in developing countries. All right, the first question we have now is about coughing. I've been coughing for a year. Nothing's come up in the screenings. What's the next step? I mean, there's a lot of causes for cough. That's a diagnostic dilemma.
It can be. So cough's a common symptom. We all cough sometimes. When cough becomes persistent beyond 8 weeks, in other words, I'm coughing daily for beyond 8 weeks, then there are 3 common causes. By far, 90% of the time, it's going to be related to asthma, related to upper airway cough syndrome, rhinitis, nasal drip, these sorts of problems.
So the nasal drainage is doing the coughing. Yeah. So it's asthma, nasal drainage.
Nasal drainage, yeah. We call that upper airway cough syndrome. And then esophageal reflux, heartburn, or GI-related cough, stomach-related
So the
issues.
stomach stuff comes up, pours into your throat at night in particular, and there you have it.
Make you cough.
That's amazing. 90% are from those causes, not from a virus.
No.
And allergies will give you that nasal drainage thing.
And can make you cough. And that's part of the upper airway cough syndrome is the allergy component. And
Right.
so there's a nice algorithm that all of us understand as far as diagnosing and treating chronic cough.
Which is, let's get a chest x-ray, pulmonary function test.
Yep, so spirometry, which is a type of PFT. A chest x-ray often is indicated, not always. And then empiric therapy for those most common causes, steroid nasal sprays, proton pump inhibitors for acid suppression. Protonics, Nexium, Prilosec. And oftentimes a 2-week trial of therapy is more efficient and effective than trying to do special testing like acid probes and all of these.
If you think that you've got a little heartburn, try a little omeprazole over the counter.
Yep,
2 weeks. See if it takes the cough. Here's COPD for 5 years. Steroids are the drugs that seem to help. Why is that?
So it's an inflammatory condition, right? So asthma and COPD, we'll talk about COPD now, are inflammation, and steroids inhibit inflammation. They prevent it. So that's why they are effective. The problem with systemic steroid shots or IV or pills are the side effects related to long-term
So if you inhale
therapy.
the steroids, it just
safer. Yeah,
puts
safer.
it right where it's
Puts
at.
it in the lungs and much less systemic absorption, so side effects are much less.
But they're always so darn expensive.
Yeah, that's a tough part of it. We get a lot of samples, and there are programs provided by the drug companies and elsewhere to assist with the cost. But that's
I wish that was generic. Why aren't we getting generic inhalers? Has shortness of breath with exertion. What should he do? What could be done? What is the problem? Shortness of breath. That's a great question.
Right. So shortness of breath, again, a common symptom. If I go out and run up 2 flights of steps, maybe even 1 these days, I get short of breath because I'm out of shape. So shortness of breath can not only be due to lung problems, but to being deconditioned, being overweight. If you put on 10 or 15 or 30 pounds, it's the same as if you were to carry that much more weight upstairs or just walking on a flat. So a lot of my shortness of breath is from patients who are out of shape and overweight. But the other common causes are heart and lung conditions. And there are specific screening tests, the number one being spirometry. So if you're at risk for chronic lung disease because of smoking, because of your occupation, because of whatever other cause, a simple screening test called spirometry is critical.
So going to the doctor, getting spirometry.
Yep.
Bronchiectasis.
Yeah.
When are lung transplants needed? Okay, what is bronchiectasis? What about lung transplants?
Yeah,
Great question.
Yeah, good questions. Bronchiectasis is a condition of an abnormality in the size of the small airway. So it's separate from COPD. If you have bronchiectasis, we don't consider you in that COPD group, although it does cause chronic obstructive symptoms. And cystic fibrosis is the genetic condition most commonly associated with that, and that occurs in Scandinavian and Western European populations.
Right.
And what happens is the airway gets injured by infection and mucus and begins to dilate. And most cases of bronchiectasis don't progress to the point where they need a lung transplant. It can be managed with inhaled steroids and what we call pulmonary toilet and hygiene. But cystic fibrosis patients, in many instances, if they don't have other complications that prevent it, will need transplants. Transplants are necessary for a lot of other reasons.
How about cutting out those segments of the lung that are not functioning?
Yeah, there are occasions when it's limited to a specific portion of the lung where you can remove that part of the lung that's diseased.
Okay. This gentleman is a carpenter from Webster. How effective are dust masks?
Yeah, so that varies. Some are not effective at all, and so you have to look at what they're designed to do. And there are HEPA filter masks, with the little screw-in canisters, that are the most effective at preventing particulate matter from getting into the lung.
Well, the 3M mask.
Yeah,
What
3M
about
makes
that?
a HEPA filter. The others are good at preventing exposure to like viruses and other things, but the best ones are the OSHA approved, the more expensive and can be replaced.
These canisters,
yeah, with
types
the
of
canisters
things.
on.
But you get a lot of particulate when you wear just the plain old 3M mask.
Yeah, unfortunately that doesn't provide as much protection. It's still better than nothing at all.
All right, so I'm a big fan of masks for people who may have problems, and it warms the air and so on and so forth. His friend had congestion around the heart, was told to use a scale every day to see if he was retaining water. What's the deal with that?
Yeah, so one of the best ways, you know this as well as an internist, to determine whether or not your fluid balance is increasing is to get on the scale. First thing in the morning, I tell my patients in the same outfit every day, get on that scale.
Most of them is a naked outfit.
Yeah, sure, that'd be the best if they can do that, or if their spouse can tolerate that.
Put a little mark on the...
and know what your weight's doing. And if it's going up, and what I often tell my patients is by, 2 pounds in one day or 4 to 5 pounds in 2 days, they're retaining too much fluid, something's going wrong. Yeah. And that's a way to prevent them from progressing to a serious illness that results in hospitalization or even death.
Fluid overload, and for goodness sake, one of the most powerful and most important medicines that I prescribe every day is a diuretic.
Sure. Water pill.
But the problem is that there are all these people who have been told over and over again that they're not drinking enough water and they're just pouring this. What do you think about that?
Yeah, so a patient who is concerned about fluid retention needs to watch intake as well. So they need to limit their intake, and oftentimes pretty strictly to 1.5 to 2 liters of fluid a day. So this idea that Oprah or others promote, drink 8 big glasses of water a day, that's not right for everyone.
No. Hayward in Iowa says, what causes excessive mucus? Mucus formation. Good question.
So the most common reason that I see patients with too much mucus is chronic bronchitis. By definition, that's a cough productive of sputum.
There's a low-grade chronic infection.
Inflammation. And not just infection, inflammation. And so those patients who are at risk,
and the most common cause is?
Smoking.
Okay.
Yeah, so smoking, but it can
dust
be present.
exposure and
occupational exposures can result in that. And then other conditions, chronic sinus disease and that. And so when you're making too much mucus, it's a sign of inflammation in the airway itself, and there are ways to suppress that inflammation.
Steroid inhalers.
Yes, most commonly, but also removal from the inciting source.
Really fast. Son had lung infection test to diagnose asthma. He's about 15. What should the lung function test be repeated, and could this asthma turn into COPD?
Asthma can turn into COPD. Spirometry, if it's abnormal, treatment should be offered, and then spirometry should be repeated within a window of about 6 to 12 weeks.
Wow, important. Great questions. We often talk on this show about trying to lose weight, but for a person with a chronic respiratory disease, too much weight loss can be a concern.
In more severe versions of pulmonary disease, it can be common to experience difficulties when eating. Shortness of breath, coughing, and chest discomfort are common symptoms to experience with pulmonary disease in general, and can worsen with eating. Eating small, more frequent meals can help lessen these symptoms and make eating more enjoyable and not so much of a task. Eating smaller portions of foods you typically eat at meals is a great place to start. Add additional portions of these foods at snacks or try other healthy foods. It is also common to have difficulty maintaining your weight with pulmonary disease. Due to the difficulties with eating, it can be hard to consume the calories needed. Therefore, boosting your calories in healthful ways might be a necessity. Add calories by adding snacks, as we previously discussed. You can also add healthy beverages that contain calories, such as milk or 100% juice. Adding a condiment such as peanut butter to your bread or foods can also be an easy way to add healthful calories. And finally, it may be beneficial to plan ahead for meals or ask for help with cooking. When being short of breath, cooking alone can be wearing.
That was great, Katy. Thank you so much. You know, there is healthy calories she's talking. Any comments about that?
Yeah, no, I think it's very important for my patients with chronic lung disease to maintain their body weight. As she mentioned, at baseline, when you're fighting for every breath, you're burning more calories than someone who's not.
Yep.
And so you want to get good, healthy calories, proteins and carbohydrates that are healthy for you. And you want to do that sort of separated throughout the day.
People who have CO2 retention, I mean, they've got bad emphysema and are retaining CO2. Sometimes we put them on a low carbohydrate diet. What do you think of that?
I don't know that that's entirely necessary. I think, you know, that's been overplayed a bit in my opinion.
All right.
I think it's most important for my patients to get enough calories, and I encourage them to use supplements like the Ensures and the Boosts that are out there, or milkshakes or those things.
All right.
But get enough.
All right. How about lung transplants? We talked about that a little bit. You deal with lung transplants?
We do. Lung transplantation has come a long way, even in the last 10 years or so since I left fellowship.
Well, that would because we can turn off the immune system.
That's the key thing, is that the immunosuppressant agents, the drugs that prevent our body from rejecting the transplanted organ, are getting better and better. And so it's important for patients who have severe lung disease that is expected to end their life prematurely to consider getting listed for a transplant.
All right. How about, here's one from Sioux Falls, causes and treatment of sarcoidosis.
Yeah, so the causes we don't know. Sarcoidosis is
have no idea.
Have no idea what causes it.
We used to think pine trees, Norwegians, Finns.
Yeah, we don't know. It's a completely unknown cause. It's inflammation within the lymph nodes and the lungs most commonly, but it can affect every organ in the body.
Okay.
And we don't know what causes it. There's a great treatment called steroids.
Right.
So they
steroids.
Work,
there we go again.
They
but
work
it does
almost in
lung.
every
But
instance.
where else can it occur?
It works. It can occur in the eyes, the liver, the brain, the heart. There are other agents, chemotherapies that can be given. In many instances, patients with sarcoid don't need any treatment at all. So oftentimes in my practice, it's someone on a treatment for sarcoid who doesn't have an indication. They have an abnormal x-ray and they have sarcoid, but it's not active. So that's another key thing, is just because you have it doesn't mean you need to do anything.
I have a patient with sarcoid that reoccurred on her low legs, erythema nodosum, went away with the steroids. And it came back several times, and then it's never come back in the last 5 years.
And you can also use the non-steroidals to treat the aches and pains and rash associated with sarcoid.
I had one who had patches in the lungs, and the question was, is this lymphoma? Is this sarcoid? Absolutely. And it was sarcoid.
Yeah, and you can, and I do a procedure called bronchoscopy that can help to make that diagnosis with minimal invasion.
Do you do a lot of bronchoscopies,
Yeah, I
Mike?
do as many as I need to do.
Yeah.
So some weeks there's 3 or 4 that I do.
You pass a scope down in the lungs.
Scope into the breathing tube through the mouth to take samples from the lymph nodes in the lung.
Mostly looking for lung cancer.
Yeah, lung cancer, but other different diseases.
Well, sarcoidosis.
Sarcoid and lymphoma and causes for cough, foreign body removal, just depends.
Oh yeah, people inhale olives and what have you pulled out of lungs?
Pistachio shells, peanut shells, parts of vegetables. I've taken a thumbtack, a little push pin that a young man inhaled. The most recent was a filling. It was at the dentist, and the dentist didn't have the dam in the right place, and the tooth broke, and the filling went into the lung.
Winter, South Dakota, sister with COPD, drain fluid from the lungs. Is this lifelong or temporary fluid in the lung?
Yeah, so pleural effusion. I see that every day, caused by a variety of different
cancer
things.
Mostly.
Yeah, it can be a malignant cause. Heart failure can do it. It can be related. Right now, I have a gentleman in the hospital who's got pus in that space, an empyema.
Well, that means he gets a chest tube. Absolutely.
Yep, he had to have that drained. And so she probably won't need that to be drained recurrently if they figure out exactly why it's happening. So when the first time we drain that fluid, fluid. We test it. Dr. Light gave us some criteria to look at.
Is it a transudate or an exudate?
Right. That helps us answer what the next step as far as managing it is.
So oftentimes people with COPD and who have fluid, they don't have a lung thing cause for the fluid, it's heart.
Can be, yep. So heart is the most common cause of bilateral pleural effusion.
Both sides.
But you need to get to the bottom of why the fluid's there.
Yeah. Inhaled steroids, increased risk for osteoporosis. What are the risks versus benefits? Okay, there it is, osteoporosis. What do you think?
Yeah, so there is potential risk with any form of steroid for side effects, and one of those can be promoting loss of calcium and bone density. And so I think that has to be considered. In patients who already have osteopenia, thin bones, or osteoporosis, the true disease of it, of loss of bone, you need to use the minimum amount of steroid necessary to control the disease that you're treating.
And you try to do it topically in the lung, not
That's right.
systemic like pills.
So it isn't true that there's no absorption from the lungs, but it's much, much less systemically absorbed. In other words, it doesn't get to the bloodstream where it can affect the bones when it's inhaled versus when it's taken orally.
And it hits where it needs to be done.
Correct. But it is a concern in some patients.
The most important treatment of osteoporosis, I'll say this again, is exercise.
It helps.
There you go. Wilmot, South Dakota, 57-year-old man who has sinuses been plugged. Could it be allergies? Could it develop allergies later in life?
Yeah. So sinus disease and asthma are closely related to one another, oftentimes related to allergies. And there are many things you can do to control that. There are steroid nasal sprays. There's nasal irrigation, I think a very underused treatment for patients.
Saltwater nasal?
Yep, saltwater nasal sprays.
Air.
Twice a day. Air, ocean mist, neti pots. And what happens oftentimes is patients go and they have sinus surgery and they think that's going to cure their chronic sinus problem. It only corrects the problem temporarily. They need to use those treatments to prevent it from worsening. And I many times see patients with cough and wheeze, and it's their sinuses that's driving it. And these treatments can prevent it.
I think steroid nasal spray is a way underutilized thing. And now, over the counter, cheap, nasal quart, is that what it is?
Yep, that's the new one that's available over the counter.
Nasal quart, over the counter, cheap steroid nasal
For
spray.
sinus, allergy symptoms, it's great.
Wow.
Drippy nose.
Brookings, relationship between lung cancer and Wegener's disease. What is Wegener's granulomatosis?
Wegener or Wegener's granulomatosis.
Wegener's.
Yeah, we used to refer to it strictly by that. It's now referred to as a granulomatous inflammatory disease, and it's an autoimmune phenomenon. That means the body reacts to its tissues inappropriately, and it forms these granulomas, and
they look
dirty,
like TB.
They're dirty appearing granulomas. In other words, they have lots of inflammatory cells, neutrophils in them.
Okay.
And they destroy portions of the lung and cause nodules and cavities in the lungs. Can look like tuberculosis, as you described. It can affect the kidneys as well. It's one of the diseases that has pulmonary and renal manifestations.
And sinuses?
Sinuses all the way through the airway, so from the nose and mouth all the way down into the lungs.
It's a tough disease.
Serious disease that used to kill people routinely, but now we have excellent treatments.
What are we using? Methotrexate?
Cytoxan primarily.
Okay.
So it's a chemotherapeutic agent, but sometimes plasmapheresis in the initial treatment of it, but not always. But anyhow, with respect to lung cancer, I'm not aware of a direct association. I could be missing some recent data, but I'm not aware of a direct association between having vasculitis. There's Wegener's, and there's one called microscopic polyangiitis. They're ANCA associated, but I'm not aware of an increased risk for cancer. At least it's not coming to
But sometimes it's hard to decide, is this cancer or is this...
Yes, it's hard to know when there's a spot in the lung, and that's where bronchoscopy...
And so a guy who's half German, how would you say that again? Wegener's. Milbank, 70-year-old wife has sore throat for 3 to 4 years, have not found a cause yet. Thoughts?
Interesting. I don't know what that might be from, but it's important that she's had the appropriate evaluation.
In other words, bronchoscopy and looking.
Or laryngoscopy. And again, most of the chronic sore throats that I encounter are from an upper airway cause, so it's nasal drainage or inflammation from
nasal
allergies.
Nasal quart.
Yeah, I think that's worth a try if they haven't done that yet.
Sometimes people irritate their own self. If they have a rash, they scratch it, and they have a scratch-induced irritation. Could she be doing too much
Absolutely.
causing the problem?
That's another issue with my chronic coughers who I can't discover a cause. Difficult to diagnose or treat cough. If cough kind of begets cough, so that tickle, if you can ignore it, and as opposed to cough or clear your throat, you're going to be much more likely to get rid of it than otherwise. It tends to perpetuate.
So I put steroid on that rash and say stop scratching it and it gets better.
Correct.
Do the same thing with some of that.
Yeah.
If you are elderly and have a curved back, hunched over,
Yeah,
can that affect shortness of breath?
Absolutely. So restrictive lung disease, too small a lungs. Some patients are born with pectus deformities,
where
or severe,
it's that concavity.
or severe curvature of the spine. Runs in families often. Grandma was bent over and curved, mom is, and so am I. Or they have diseases like Ehlers-Danlos, but those cause lung volume restriction. And so if you have a curvy spine or other chest wall deformities, you should have pulmonary function testing.
Can you do something about it?
Sometimes surgical correction is beneficial in those patients, but in many instances you just have to be careful not to let other things develop.
Lung exercises?
Of questionable benefit. Most important thing is to be active.
Okay.
So the more you use your lungs, the better you do.
Exercise. How important is exercise?
It's critical. So just quickly to try to point this out, COPD is classified 4 different ways based on severity. Breathing tests can tell you how severe your obstruction is, but we classify those groups then into A, B, C, and D. It's the patients who are active and who have fewer exacerbations that do the best, regardless of how severe their lung disease is.
Activity. There you go.
That's key.
We'll be right back after this.
What would you do to save your child's life? Secondhand smoke can kill them any number of ways. So, would you stop smoking around them? Would you ask your family and friends not to smoke around them? Would you keep them away from places where people smoke? Of course you would, because you can choose. They can't. It takes courage to stand up for your child. But if you don't, who will?
He was a trucker and overweight like a lot of these guys and gals who dragged freight across the country, and his wife came with him to make sure that he told everything. He described struggling to stay awake while driving that had been going on for years. But as he's gained weight and grown older, the problem's been getting worse. Then she added, he snores loudly, and recently she's heard spells of not breathing followed by a snort, coughing, and up to the bathroom. This informed wife said to me, "Do you think he could have sleep apnea?" She was right. The diagnosis was confirmed by a sleep study, and I think treatment saved his life. His was the classic case, which includes a wife who worries about her husband snorting during sleep. Sometimes patients with this condition don't come in with such a perfect picture, however. They might have only a morning headache, an irregular heart rhythm, worsening leg swelling, and increasing nighttime urinary frequency, anger and memory issues, or even just a dry mouth. Or worse, it may be severe hypertension, or a new heart attack or stroke, or a sleep-induced motor vehicle accident. Although sleep apnea is more common in men, smokers, the obese, and the elderly, it can also occur in women, non-smokers, thin people, and youth, even children. It runs in families with inherited anatomy like short necks, recessed jaws, small nasal passages, and is made worse in those who take tranquilizers or sedatives or alcohol before bed. Experts now estimate that at least 12 to 18 million Americans have moderate to severe sleep apnea. That's about 5% of the population, and likely that number is higher since this condition too often goes undiagnosed. In a 14-year Australian study of 30 to 65-year-olds, about 7% of the people without apnea died over that period of time, while 33% of those with moderate to severe sleep apnea died, almost a 5-fold difference. A similar increase in death rate with sleep apnea was found in Wisconsin study. Here's the good news. There is reduction in death rate with treatment. Do you think you could have sleep apnea? Don't wait for your wife to get you to the doctor. Ask about having a sleep study. It could save your life. We got 30 seconds. Any bottom line about sleep apnea?
Sleep apnea is a common condition, and once you get older and you're getting heavier, it's even more common than 5%, 10%. And the symptoms are not always obvious to the patient. So if you're snoring, if you're sleeping poorly, if your spouse is concerned, ask your doctor.
Thank you, Mike. This brings us to the end of our show this evening. I sincerely thank our good friend, Dr. Mike Pietila, for helping answer our audience questions this evening. What a great run. As often happens in this show, time ran out. We didn't get to all our great questions, so to hear your answers, go to oncalltelevision.com and view our answers to the questions we didn't get to. We'll be live on call after hours in the web in just a few minutes. And we end with a poem from author-poet Andrea Gibson. And I wonder if Beethoven held his breath the first time his fingers touched the keys, the same way a soldier holds his breath the first time his finger clicks the trigger. We all have different reasons for forgetting to breathe. Until next time, stay healthy out there, people.
Funding for On-Call Television is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On-Call Television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Dakota Care, Brookings Health System, Dakota Allergy and Asthma, Dakota Dermatology, Aberdeen Asthma and Allergy, the Orthopedic Institute, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, Brookings Health System, and Fishback Financial Corporation.